the use of iris hooks to support the capsule and the bag in hard rock cataract. 85-year-old lady with pseudo-exfoliation and cataract, with the history in the other eye there was a subluxation of the lens, and doing cataract for these patients with this old age usually is very challenging. Iris hooks are valuable in these cases to dilate the pupil, as the intracameral injection of epinephrine did not help to dilate the pupil. Putting the iris hooks in the places where it can help to dilate the pupil fully to do your rexes, and another fifth incision for the support of the side port, then the 2.2 millimeter keratome incision with injection of viscoelastic material in the anterior chamber. Once you start the capsular rexes, you see that the whole lens is subluxated in nearly all the quadrants, trying to maintain the capsule as much as they can, the capsule rexes, by the capsule rexes microincisional forceps with the second hand iris spatula helps to support the lens in order not to move while doing the capsular rexes, completing the capsular rexes and being small rexes. So you should put in mind to keep all of the time putting the phaco phaco tip in the middle of the lens. Then the capsular hooks or the iris hooks were used to support the capsule by putting the iris hook inside the anterior capsule, and this supported the capsule so much and the whole lens in the 4 cardinal sites at 6 o'clock and at 10 o'clock and 3 o'clock and 9 o'clock. Then the hydrodissection with the supported nucleus and starting doing your phacoemulsification in this hard nucleus, having another side opening to be at ease as a second hand to support the phaco tip while it is inside the nucleus. Phaco 1 by doing the ultrasound, high ultrasound and low vacuum, then a division of the nucleus into 2 halves, the stop and chop technique, till removal of the whole nucleus. And then while removal of the epinucleus, it is noticed that the whole capsule is coming as you see here and then turns back, which means that the whole capsule is very luxated with no support at all of the zonules. Removal of the remnants of the small epinucleus and the lens matter with the irrigation aspiration cautiously in order not to hold the capsule itself. And after finishing the removal of all the contents of the capsule, nucleus and epinucleus and the lens matter, leaving the capsule very clear, but there is no support at all. The area where the only iris hooks are not supported inside the capsule is the area where the zonules again is very luxated and very weak. So the decision was taken is to remove the whole capsule because this will not be supported by any means of fixation, whether by putting capsular tension ring or any other way. Being 85-year-old lady, remove the whole capsule out and there is no vitreous at all, seeing the capsule whether it is complete or any remnants inside. As you see here is the bag with the edges and the zonules are very weak at this patient. So removal of the iris hooks, trying to constrict the pupil by injection of myocol, and after the pupil had been constricted, starting putting your artisan or very size IOL in the anterior chamber supported by the iris itself. So the iris fixated IOLs are very valuable in these cases, preferable here to put it in the anterior chamber, not the posterior chamber, as if there is a risk of loss of the inclination anytime, it will be easy to reclip it or re-inclinate the edges of the artisan of various heights, enlarging the wound, putting the 6 millimeter anterior chamber very size IOL, making it horizontal, and after that so holding the lens with the special forceps and with the inclination forceps from the side port, taking part of the iris to be inclinated inside the edges of the lens with a good grip, good centralization, peripheral iridectomy, closure of the wound with 3 sutures and this was the safest way for this patient to have a small wound, not a large one, and having the IOL in the anterior chamber supported with the iris through the by the artisan lens. Thank you very much.